There can be some complications associated with the colonic diverticulosis. And if we talk about these, there can be diverticulitis, there can be abscess formation, there can be localized or generalized peritonitis, there can be intestinal obstruction, there can be hemorrhage, or there can be fistula formation. Almost all of the complications we already talked about in jejunal diverticula and the Meckel's diverticula. Now, there's a classification system, which is the Hinchey classification of the complicated diverticulitis, and it's actually 4 grades, and grade 1 is mesenteric or pericolonic abscess. Grade 2, that means the inflammatory process that extended far beyond it, and it's involving the pelvis as well. So grade 2 is a pelvic abscess. Grade 3 is purulent peritonitis, and grade 4 is a fecal peritonitis. So whenever the complications have already been developed, now you can drain the mesenteric or pericolonic abscess. Percutaneous drainage can be done if the abscess is small, like less than 5 centimeter. But if the abscess is large, greater than 5 centimeter, then you have to go for the open drainage. For the pelvic abscesses, for purulent peritonitis, and for the fecal peritonitis, again, the safest option is you go for the open surgical procedure. Now, talking about the management for the diverticular abscess, which is a complication of the diverticular disease, if there's an algorithm which has to be followed, if the size of the abscess is less than 4 centimeter, you just try to treat your patient with IV antibiotics and you give bowel rest. If there's a good clinical outcome, then you go for a close observation. And if there's a poor clinical improvement, reassess your patient and just try to do the percutaneous drainage or the surgical drainage. Now, if the size of the abscess is greater than 4 centimeter, then you have to think if percutaneous drainage is amenable or not. If percutaneous drainage is possible, then you go for percutaneous drainage, and then there's a possibility that there's a good clinical outcome. If there's a failure or poor clinical outcome, then you have to open your patient and you have to do the open surgical drainage. If the percutaneous drainage is already not amenable, then you have to go for the surgical drainage. So remember this algorithm for a diverticular abscess, and the size of, in some books, it's mentioned as 5 centimeter, and in some books, the cutoff value is 4 centimeter. So you can go either way. If size is less than 4 or 5 centimeter, put your patient on IV antibiotics, give bowel rest, and try to manage your patient conservatively. If there's a good clinical improvement, continue antibiotics and monitor your patient. If there's a poor clinical improvement, now you have to see if the percutaneous drainage is amenable. If not, you have to go for open surgical options. And if the size is greater than 4 centimeter, and percutaneous drainage is amenable, then you do the percutaneous drainage. If there's a good clinical outcome, then your job is done, and monitor and close observations. If there's a failure or there's a poor clinical improvement, then you have to go for the open surgical drainage. So that's how you're going to manage the complications. And again, other complications like the fecal peritonitis or the purulent peritonitis, obviously you have to do the open surgical drainage. You do the exploratory laparotomy and wash the abdominal cavity with almost saline. And if we talk about the if the usually colonic diverticulosis is very extensive, and most of the time a significant portion of the colon is involved. But if it's limited, you can go for limited resection and you can do the primary anastomosis, okay? But sometimes if extensive portion of the colon is involved, and then it depends upon the clinical conditions. Either you have to go for pancreatectomy or not, and you have to weigh if there are chances of malignancy or not. There are a lot of things you have to think about while doing the pancreatectomy. But if there is a limited resectable diseases there, then you can go for the limited resection of the colon and you can go for primary anastomosis. But if extensive disease is involved, then you have to see if you can go for pancreatectomy, or if your patient is actually it would be able to tolerate the pancreatectomy or not, and obviously the patient will have to be put on a permanent ileostomy. So all these things you have to manage, and then the complications are managed accordingly. Abscess and peritonitis, and most of the time they're managed accordingly. Sepsis is if the disease is unresectable, then obviously you can just do the open surgical drainage. So that's all for today's lecture. We have been talking about the jejunal diverticula, the congenital Meckel's diverticula. We also talk about the colonic diverticulosis and their complications, and some of the classification systems, and how you are going to manage your patient on a medical treatment and a surgical treatment. Thank you for watching sqadia.com.